Hi, my name is Natalie Montijo, and I'm a registered nurse as well as a licensed acupuncturist. And I run a SNF, a skilled nursing facility in Berkeley, California. And I am your TA for Geropsych. And I'd like to talk to you a little bit today about dementia. Dementia is a big, big deal in 21st century America, and it's only going to get bigger, unfortunately, as our population ages. In dementia, there are four different subtypes, and that's what we're going to actually get into right now. The first and most prevalent is, of course, Alzheimer's. Most of the dementia that you're going to see is Alzheimer's dementia. Alzheimer's dementia is progressive, it is slow, it takes years and years and years, and it is a very heartbreaking and difficult situation. Um, Brain changes that are associated with Alzheimer's include actual shrinking, a physical shrinking of the brain. If you look at a brain of an Alzheimer's patient versus a normal brain, it's significantly smaller. In terms of the physiology, the pathophysiology, what you're going to see in Alzheimer's are what they call neurofibrillary tangles, which are the communication channels of the brain become tied up and just not functional. You'll also see the development of what we call plaques, and plaques come from abnormal proteins or abnormal processing of proteins. So you'll see senile plaques is what they're called, as well as neurofibrillary tangles. So basically the brain has, to put it technically, a lot of crap it shouldn't have in it, and a lot of the passages are not going the way they need to go. People with Alzheimer's dementia have a progressive memory loss, which just keeps getting worse. You may see people repeat statements and questions over and over again, forget conversations, appointments, events, and have no recollection of things that happened just minutes ago. We had a guy at the facility who would leave his room shortly after breakfast and say, I haven't had breakfast. And we would say, you did. And he'd say, no, I didn't. I didn't. Finally, one of the nurses actually started taking a picture of him with the breakfast tray and showing it to him. And he said, I guess I did. Um, a lot of working with people with Alzheimer's involves a tremendous amount of redirecting, of goodwill, of sense of humor, and reassurance. Reassurance is big. People become very frightened. People become very confused, and you really want to always remember to try to function as much in a reassuring, almost a touchstone manner as you can. So, people with Alzheimer's may also lose their spatial sense. There's a wandering component with Alzheimer's, which can be very dangerous because people can wander away and have no idea where they're supposed to be, and in many cases, even who they are. They may find it difficult to understand their surroundings. So, in the SNF, what we try to do is keep people's rooms um, as easy and user-friendly as possible. You don't want to have things in odd places. You want to make it very, very clear. And even then, it may be difficult for somebody with advanced dementia to get it. They may have trouble finding the right words to identify objects, express thoughts, or take part in conversations. And of course, after a while, the ability to read and write is no longer going to be there. Hard time concentrating, thinking, especially about abstract concepts and numbers. Um, the really heartbreaking thing is people forget everything, down to, of course, how to bathe, how to dress, the mechanics of toileting, and down to how to swallow. Which you think you couldn't forget that, but it does happen. So of course, at that point, people really can no longer eat. It's very common to see depression, anxiety, social withdrawal, mood swings, distrust, increased stubbornness, irritability, aggressiveness, changes in sleeping habits, and wandering. Um, Alzheimer's kills the brain cells. You're going to find in Alzheimer's more, certainly I think it's unique to Alzheimer's, a phenomenon called sundowning. You may find people becoming more confused and more agitated as the sun goes down. About 4 or 5 o'clock, you'll see in any given SNF that you visit, any given nursing home that you visit, you will see people who sundown begin to really activate at that point. And then it's time for staff members to remember to redirect, to reassure. Sometimes certain medications are given at that time as well. The medications that are given, again, from the medical standpoint, basically two types, what we call cholinesterase inhibitors, and these kind of boost the ability of cells to communicate. Um, there's a certain amount of helpfulness with that, and the problem with dementia is it has a really inexorable quality to it. So you can be giving people cholinesterase inhibitors in the hopes that it's going to boost cell-to-cell communication, but the jury's out. The other class of drugs are called cognitive enhancers. Cognitive enhancers are also supposed to help to preserve the functioning that you have and preserve the ability of cells to communicate. Namenda is the most popular drug for dementia. Memantine, pardon me, is the generic name for it. The cholinesterase inhibitors that you're going to see mostly are Aricept and Exelon, but mostly you're going to see Aricept and Namenda. 7 to 9 people out of 10 will be taking those with dementia. They may or may not be helping. I've seen quite a number of people on them. I have never seen somebody, unfortunately, really improve, but it may be preventing them from declining as quickly as they would. In terms of alternative medicine, omega-3 fatty acids, fish oil, which we're discovering is good for just about everything, from dementia to ADHD, depression, you name it, heart disease. Vitamin E. Vitamin E has been linked to a delayed loss of ability to carry out daily activities. Good enough. Vitamin E is a wonderful thing. You know, in insane doses. Ginkgo biloba, and there's a couple of Chinese herbs as well. So you definitely want to be. These are things that a patient would want to be working with a qualified practitioner on. For psychologists, for therapists, in terms of making assessments, you're going to want to do a mini mental status exam. You're going to want to do things like drawing a clock face. You ask your patient, your client, to draw a clock face with a specific time and see how well they do. See if they can actually draw the face and put the numbers in order, if they can set the time. You can see how far along somebody is fairly quickly. Of course, check their orientation. What's today's date? Where are we? What year is it? Who's the president? Have them copy a design, such as 2 intersecting pentagons. Follow a 3-step command. Get up out of your chair. If the person is mobile, go and get the cup and bring it back. Remember a list of 3 words spoken. So when you're going through your assessment, give them 3 words: sock blue bed, and then 5 minutes later say, do you remember the 3 words? See if they can. Have them write a complete sentence with correct punctuation, and of course count backwards from 100 by sevens, which is, challenging enough in the non-demented person. Something else for you to know is when you're working with a person with Alzheimer's and they become activated, go into an actual episode, know that the activation is going to last about 30 minutes. And after that 30 minutes, it's going to be gone from their memory. It'll be as if it never happened. So if you can redirect, if you can reassure, you're looking at about 30 minutes worth of time. Brain fitness exercises, although we don't have a lot of evidence-based medicine or any to prove that it's helping, anecdotally, it is helping. People who do Sudoku puzzles, people who are engaged, people who take classes, older adults who are still really involving themselves in the game of life tend to do a whole lot better. So anything that smacks of brain fitness, I think, is a positive and worth pursuing. The Alzheimer's Association is an excellent, excellent, excellent resource for you, and there's a module on behavior, and I highly recommend going there and checking it out. That's Alzheimer's. The second most common type of dementia is called Lewy body dementia. Lewy body dementia is differentiated in that you may see more from Alzheimer's, and that you may see more symptoms that'll look almost psychotic. You may see hallucinations. You may have people seeing shapes, colors, people, or animals that are not there, at least not there for us. They may even be having conversations that, are not, don't involve us. You're going to see significant fluctuations in alertness and attention, daytime drowsiness, and then you may see some staring into space. The other thing you may see is a Parkinsonian component. Lewy body dementia and Parkinson's disease tend to be paired a lot of the time. Parkinson's has the characteristic tremor, this sort of pill rolling in the fingers, but kind of a lot of shaking, a very unsteady ataxic gait. That's what you're going to see in Parkinson's. In Lewy body dementia, it's abnormal round structures called Lewy bodies form in the brain out of certain proteins. They're not normal. They shouldn't be there, and they tend to develop in the areas associated with thinking and movement. So these folks are going to have hallucinations, movement disorders, delusions, like Alzheimer's, the cognitive stuff, sleeping difficulties, and fluctuating attention. Let's see. Also, of course, these people are going to have the plaques and the tangles associated with Alzheimer's. It's kind of the mark of a dementia, that you're really going to have some brain abnormality. So men are more susceptible to Lewy body, women are more susceptible to Alzheimer's. And let's see if there's anything else you should know. Just understand that with Lewy body, you may see more behavioral stuff. We had a guy in my facility with Lewy body dementia who was a very the delusions were definitely a big part of it, but he would call out a lot, and he would call out just his degree, the degree of desperation in his calling out could be that he wanted the volume on the TV changed, or that he was in terrible pain. There wasn't that ability to really differentiate. Okay, moving on. We've done Alzheimer's, Lewy body. Number 3 is vascular dementia. And vascular dementia is a general term that refers to problems with planning, judgment, memory, and other thought processes caused by brain damage from impaired blood flow to the brain. So you may see vascular dementia after a stroke. Very, very common. But of course, not all strokes are going to cause vascular dementia. Risk factors are the same as for heart disease and stroke. High blood pressure, high cholesterol, smoking. Let's see, symptoms. Symptoms overlap, especially with Alzheimer's. But if you see dementia symptoms right after a stroke, in the recovery period, it's a pretty safe bet that that's what's going on. So what we're going to be looking for in vascular dementia include confusion, difficulty paying attention and concentrating, reduced ability to organize thoughts and actions, decline in analytical abilities, difficulty deciding what to do next, problems with memory, restlessness, agitation, and unsteady gait, sudden or frequent urge to urinate, or the inability to control passing urine. And do keep in mind that incontinence is a part of every dementia, especially towards the end. Certainly you're going to lose the ability to control bowel and bladder before you lose the ability to swallow. But it's a very, very sad thing to see. There is wandering associated with vascular dementia and depression. So folks with vascular dementia are also at increased risk for stroke. And that's, pardon me, for seizure, as well as stroke, because they've probably already had one, especially, you may or may not know that if you've had a stroke, that is a risk factor for more stroke activity. But people with vascular dementia are also at increased risk for seizure. So the other thing you may see here in vascular, also very heartbreaking, is you may see what we call a stepwise decline. So a person may be plateaued at a certain level of functioning, and then you may very dramatically see a step down, and they may plateau out again, and then the same thing will happen. Unfortunately, rarely does it go the other way. The fourth type of dementia, and the least common, is frontotemporal dementia, which tends to move pretty quickly. Frontotemporal dementia is an umbrella term for a diverse group of uncommon disorders that affects the frontal and temporal lobes of the brain. And these lobes, of course, are associated with personality, behavior, and language. In frontotemporal dementia, portions of these lobes atrophy or shrink. Some people with this kind of dementia undergo dramatic personality changes. They may become socially inappropriate, they may become impulsive, they may become emotionally indifferent, and others may use the ability to use and understand language. Sometimes it is misdiagnosed as a psychiatric problem because you can see that it would indeed look like one, but it's not. It's actually a dementia, and you're going to see this primarily between the ages of 40 and 70. So the symptoms to look for here, and again, they really are going to mimic psychosis. A lot of them are increasingly inappropriate actions, loss of empathy and other interpersonal skills, lack of judgment and inhibition, apathy, repetitive compulsive behavior, a decline in hygiene, changes in eating habits, predominantly overeating, and a lack of awareness or thinking about behavioral changes. You may also see primary progressive aphasia, and that's, of course, increasing difficulty in using and understanding written and spoken language. You may see semantic dementia, which is when somebody is going to say something grammatically correct that makes absolutely no sense in the context of the conversation at hand. So other symptoms, movement symptoms you may see in certain subtypes would be a tremor, rigidity, muscle spasms, poor coordination, and again, difficulty swallowing. Be amazed at how often difficulty swallowing comes up clinically. And it's a very, very serious situation because that's going to lead to a lot of hospitalizations for aspiration pneumonia, which is literally when a person can't swallow properly, the food goes into the lung. Very, very common in older adults who have dementia of one type or another, and a high mortality rate on that. Very difficult. Let's see. As far as frontotemporal goes, there may be a genetic component. There are some genetic mutations that have been linked to it. But more than half of the folks who develop it have no family history. But it is rare. So the odds are pretty high that you will not be working with people with that. And again, as I mentioned, that is a disease that tends to move pretty quickly and take people, unfortunately, out. So just to sort of put a fine point on it, with Alzheimer's, you're going to see a lot of memory loss, spatial disorientation, where am I, how does all this work, and language failure. With Lewy body dementia, you're going to see confusion, you're going to see physical slowness, you're going to see also some things that may mimic a little psychotic behavior. Hallucinations, delusions, that sort of thing. In vascular, you're definitely going to see a mental and physical decline. Frontotemporal, you're going to see those personality changes. And that's really going to be hard, and especially if it's a younger person. You're going to be really hard-pressed to differentiate that from an actual psychosis. Memory loss is very severe in Alzheimer's. It's variable in Lewy body, it's variable in vascular and frontotemporal. But in Alzheimer's, that's really the hallmark. And what makes this disease so cruel is it is a kind of a slow, inexorable process where you're watching people become aware, especially in the beginning, that they're losing themselves. It's a very, very difficult thing to see, but it is very satisfying to be able to provide reassurance and to really help people in that situation. To feel more in control when possible. uh, Conduct. Alzheimer's people do display appropriate concern, as do people with dementia, with Lewy body and vascular. Frontotemporal tend to be a bit more, inappropriate, wild and crazy, shall we say. Now, you may see in Alzheimer's, I have seen disrobing. Um, but a lot of the time, it just seems it isn't. It's more of a repetitive sort of a almost like an agitated kind of behavior, as opposed to, there's no process behind it. A person could just as easily be pulling off a shirt as shredding a magazine or a book. It doesn't, you don't get the sense, I haven't gotten the sense in observing that there's a process of, "Ooh, I want to, suddenly do something that's socially inappropriate." It's not that at all. Um, People with Alzheimer's, you're going to see them making a high mental effort. The other dementia is not quite as much, but you will see that, especially initially. When people are first beginning to show signs, there's a lot of fear, a lot of confusion. You'll see people writing a lot of things down, really trying to keep track. That's when you're going to see more anger coming up, because a lot of people just find it really. It makes perfect sense. People would find it very irksome that suddenly they can't remember things, something that happened very recently. They just can't keep the thread. And the other bits of this basically are talking about how things are diagnosed, which is not so much of a concern. If you're a part of a care team, it's good that you have a handle on what's going on clinically, or at least that you've had some exposure to it, because people will be talking a lot about medications and a lot about pathology. But just to understand that as a therapist, I think you're in position to do a lot of good work, but the good work that you do will have to be very focused in the present. I was involved with doing a little study at my facility where we worked with a modality called pleasant events therapy, which is exactly what it sounds like. A pleasant event is different for different people. So the first thing we did is we had a questionnaire. There's a psychologist in Louisville doing quite a bit of work with this right now, and it's a delightfully elegant and simple idea. She's created a questionnaire that you can administer to almost anybody who can answer a question, or at least express, even if they don't answer the question directly. A smile counts as a positive answer, and the questionnaire involves a whole list of potentially pleasant events. And when you go through the list, you kind of see if you get the sense from this person, either an answer, yes or no. Would you find this pleasant, or would this be something that you'd like to do? Um, and you go through a list of 25, 30 things, and you can of course come up with more pleasant events, because a pleasant event can be almost anything. What we found in our little pilot study was that just about everybody, in fact everybody who participated, said that laughter was a pleasant event, which is one of those sort of, yeah, duh, of course it is. So who wouldn't pick laughter as a pleasant event? But until we actually sort of quantified it like that, we never thought about it. So when we looked, we said, yes, of course, laughter. then we decided to come up with ways to, increase the funny. So we got a comedian who specializes in humor for older people, and he had cardboard cutouts of W.C. Fields and the Marx Brothers, and his comedy is geared towards older adults. We also brought in an Elvis impersonator, and he's been back a couple of times since, and that's a very, very popular thing. You really see people who normally have a very flat affect smiling and enjoying themselves, and it's a wonderful thing. Pleasant events therapy, or anything creative in that that's focused on the right now, I think is a great way to proceed in working with folks like this. Certain For people who are higher functioning, I know that in certain other parts of the world, they've been working with trying to do acting improvisation, because that's very present focused. Now you can't do that, of course, past a certain point, but I understand anecdotally that that's kind of a neat thing. So I would urge anybody who's interested in this work to know that the field is wide open. Creative minds are needed, wanted, and I would also urge you to spend some time with older adults in a skilled nursing facility, or adult day healthcare, skilled nursing especially, because really lots and lots of help is needed, lots of an infusion of creativity and new ideas. So hopefully that will help and give you a little bit of an idea of how one might approach working with older adults with dementia. And I would invite any of you, if you're in the Bay Area, to come pay us a visit at Berkeley Pines Care Center. Thank you so much.